real conversations, and some hard truths. Gangs, drugs, and guns. Giving a voice to those willing to sacrifice. We have stories that need to be told. We have lessons that need to be taught. Protect and serve. Welcome to The Quiet Professional. So welcome back, everybody. Nathan Rome is with you once again. And today we are talking about drug addiction, the idea of safe supply, and some solutions. And for that, we've got the big brains on the program. We've got Dr. Julian Summers from Simon Fraser University here. So Dr. Summers is a clinical psychologist and Simon Fraser University distinguished professor. Dr. Summers began his training under Dr. Bruce Allen in studies on how social experiences can cause addictions to begin and end. Dr. Summers was then mentored by Dr. Alan Marlett in advanced clinical practices focused on relapse prevention, harm reduction, and mindfulness. For 15 years, Dr. Summers worked as a psychotherapist and trained clinicians in psychology, medicine, and other clinical fields. He's consulted all across Canada and internationally. He's also earned some local, national, and international awards for research and public interest, as well as academic awards for excellence in teaching, research, and service, and SFU's Award for Excellence. He's also got time to be married with 2 sons. So welcome, Dr. Summers.
It's great to be with you, man. That makes me feel old. Let's get into our discussion.
Well, maybe you'll date yourself when we get into your personal story. So,
great.
We'll kind of start at the beginning so people get to know you. Tell us about growing up and life.
Okay. How much time you got? So I was born in London, and my mom, who same last name as me, Summers, was a very young girl and Catholic family, and I was adopted out, and I was raised in Vancouver, in Canada, brought over here, and lived in was only child in a family for my first 7 years until that family kind of fell apart. And the next few years were not the best for me, and I struggled quite a bit, especially in school, and eventually I left school pretty early and was raised by a family in Colorado, who were my godparents, but I didn't really know them much before that. And it was essentially just hard work on a ranch with other ranch hands, mostly Hispanic and Navajo workers. And they were just prepared to, like I could do that for as long as it took me to figure out a plan. And it took a couple of years for me, even just to figure out what to do. But I wound up doing courses to get an equivalency of high school, and then started at a local college. And the town was Durango, still is Durango, Colorado. I've been back there several times since. And so I started at Fort Lewis College, which is the local school. And I transferred eventually from there to Simon Fraser University because my adoptive mom was quite ill with cancer by this time. So I wanted to be around and provide her with support. Once I sort of got my feet under me. So that's kind of how I got back into school. And I was subsequently exposed to my biological parents, so my birth mother and my father, who are not together, just actually never even met after they spent time making me.
Yeah.
But I spent some time with each of them, and we were very close for a while, and then very not close, which is kind of where we are now. But I've got my family, and throughout all that time, I think looking back on it, I realized that my connections to people in mentorship roles, as colleagues, and then as trainees that I've worked with, those relationships have been hugely meaningful in my life. And in some ways, I think that the way that I was raised has, one of the blessings it's afforded me, is I'm almost always very quick to realize how fortunate I am to have conversations like this one, and to be able to do the things that I do, because I know very well that for many people it is not like this.
Mm-hmm.
Every day does not lead to encounters with other people who are decent and curious and interesting and generally mean you well. I carry that as a source of motivation in the work that I'm doing.
That sounds amazing. You got quite the life experience, even just before you get into school. So when you came from London, how old were you?
About like 3. I was sort of just barely verbal.
Oh, okay. Very young.
Yeah, I was young enough to know which football team I cheered for, but that's about it.
Standard for England, I guess.
Yeah.
So you said you came over to Vancouver and then you left school early. Like, what grade are we talking?
Well, so like the first time I had real problems in school was probably around grade 5.
Oh, really? Okay.
And I started school early. I don't know quite what foolishness led to that. I started school early, but and it went okay for the first several years actually. But it was right around the time my adopted parents split up, and it was very unpleasant for me.
Mm.
Very unpleasant for them too, but it was unpleasant for me, and that just had a really or it coincided, I guess. I'm not trying to pin everything on that, but it coincided with things really going poorly for me in a lot of ways. Just it's like socially, academically, sports was still okay, that was still all right, but and then around really the very beginning, as soon as high school. So I limped through elementary school, and by the time we got to high school, I was really, not spending all my time in class, and it was kind of, just a matter of time before I was completely withdrawn from school.
What were you finding were your best subjects in school? Because I imagine, something that led you into the field you're in now, maybe in the sciences or what have you.
I could do well at most things. This is, I was one of those kids Julian, you can do anything you want if you put your mind to it, right? I used to hate that, right? So honestly, it wasn't the objective difficulty of any of the subjects. At one point when I re-entered university, I was still kind of struggling with some mental health symptoms, or mental illness symptoms, I should say. And I took, a whole roster of courses one semester, and I failed every single course. I just flat failed everything.
Wow. And
I had to kind of plead to the university to let me back in. And they did. And I had kind of had another realization at this point. And between the semesters, I realized that I needed to work a lot. I needed to put in effort, and focus, and some of my capabilities that had been really working against me, I could mobilize for me.
Mm-hmm.
And then I got nothing worse than an A from that point on.
Wow.
In my undergrad years, and that's what got me a scholarship into graduate school in the States. Was I had this amazing, looking record of grades that was basically a product of being a study addict, right? I made this the center of what I was doing. I was working, like I had a part-time job supporting myself.
Yeah.
And at this point in history, you could do that. You could actually like pay your rent and food on part-time earnings and still go to school. But I just made that the centerpiece of my life, my academics. It was just a huge turnaround, and then started opening doors, and then I realized, gee, this is this could lead places, and I kind of haven't stopped.
And the one thing you mentioned there that I'm going to kind of pick up on, which I was thinking I would mention more in the solutions at the very end, but since you mentioned it, is anybody, no matter what anybody's struggling with, I always find the biggest part of the solution, or at least the point I've seen people turn it around on, is taking control of their own life, or accepting responsibility at that moment and saying, whatever's causing me harm or trouble, one, can I turn it into a positive or a benefit, or make it work for me? And then the other part is just you have that agency over your life. So I was like, okay, I need to be in control of some things here, one or two things, or maybe it's everything, but working, in your own favor at that point. It's the stuff I always find, and when we'll talk about some of the drug solutions here, or addiction stuff, but it's when people just kind of, I want to say, wallow in their own self-pity and different things, but also, allow other people to keep telling them what they need and stuff. Like at some point, they got to take ownership of their own life. I get it's harder for some than others, but I think that's probably one of the main pieces that I've seen from my own experience. I don't know, do you kind of have any thoughts on that?
Well, I very much agree with what you're saying, both from a more dispassionate kind of psychological perspective, and also very much from a personal perspective. And I think you're right that a key part of it in addiction, it's a cliche to hear people refer to hitting rock bottom and that kind of thing, right? But there's a subtle part of it. It's not so subtle to us as individuals trying to make changes in our lives, but to observers, it's kind of subtle. What observers see and kind of relate to, I think, is when you make a conscious decision, and you really feel it, like you feel like your body feels different when you make these kinds of decisions. It's like you are in that moment, you're not actually exactly the same person anymore. It's this little, transformation that happens, and you feel it, and then you step forward. But what's not visible in that to anyone, even to yourself, I think, is in what ways did the world around you need to change in order for you to be able to make that transformation? Right? Because so much of the work I've done with people who are really like glaringly without resources and opportunities, people who are homeless, struggling with mental illness, so their ability just to have periods of time where they're thinking clearly is diminished because of those things. And for most people in those circumstances, it's actually it's not reasonable to say make better decisions. Right? It's just so there's and I think most people get that. So there's a certain amount of help. Just to put it really broadly. As well as a certain amount of experiences with agency, that term you used, like experiencing self-control. I think there's a certain amount of that most people, maybe everybody, needs to have before they can have this kind of transformational experience that I referred to. Because I think it comes from self-belief. I think it comes from a deep down sense that even though you You don't know the details of how life can be better.
Mm-hmm.
And it's a mystery, right? You don't know what is available to you, but you're at least convinced that there is something better than what you're currently experiencing.
Yeah.
And you take a leap of faith, right? And I think that's huge, and probably something everyone can relate to.
Yeah. Well, and you know what? And maybe I'll ask this now too. There's generally, you hear that some of the users, so like we'll talk drug users, that we're looking to break down the stigma which stops them from accessing life-saving support and services. Now, this is my own personal view. I have never really bought into that statement, but can you tell me kind of where that, maybe the origin of that, or what makes that true? I've never found a good answer for it, which is why I'm saying I haven't bought into that. But it just seems like a tagline that I see in every single news article, but they never give you a reason why. Like I feel like more people just don't see, kind of like you're saying, it's a leap of faith. They don't see what, the positive that could be ahead of them. So it's hard for them to make the change. They know what they've been doing and they're comfortable with that. But for somebody to go and say like, hey, I need help, are they just thinking that the person they go to ask for help is just going to laugh at them or ridicule them? I don't really see that. So can you tell me about that, like where that kind of comes from?
Oh man, so a lot of what we refer to. First of all, I'm with you in that a lot of the stuff that I hear that refers to stigma reduction, we're going to do this, and it also doesn't make sense to me either. And I often feel kind of bad about that, because I'm a psychologist and I think, well, they're using a psychological term, stigma, so I should know really what they're talking about.
Yeah.
But the way I have made sense of it is that stigma, for starters, is some kind of sign about a person, and something about, it's like, it's stigmata, right? So it's some kind of sign, something about them, the way they talk, the way they look. They've got ink on their neck, they've got a nose piercing, whatever it is, right? The way they sound. And it's going to be some kind of sign about them that is going to cause people to react a certain way. So, and we have that in addiction, but it's not the way people in positions of authority are using the term. Because if we have doctors or lawyers or other people with addictions, we've got really well worked out forms of intervention for people who look that way, who look like people who we value in society. And those treatments work incredibly well. I mean, the however you want to examine them, the rates of people going through with the treatments, the effectiveness of the outcomes of those treatments, very, very positive. On the other hand, if you're someone who doesn't look like a stereotypically valued member of society, let's say you're unemployed, don't have much advanced education, and maybe have some mental illness symptoms as well as polysubstance, we've got a treatment system for you. But it looks nothing like the treatment system that we give to people who we value. The people who we value get essentially psychosocial and intensive forms of support that last a long time. And they are strongly discouraged from using any kind of medication, even as an aid to the treatment, like say methadone.
Oh, really? Okay.
If you're a poor person, you get only methadone and no psychosocial interventions. So to me, that is very clear evidence of stigma. You look this way, you get this. You look that way, you get that.
Okay.
Now, these treatments in our public system objectively suck. That is, they don't help many people actually overcome their addictions. If they're going to overcome their addictions, it's going to be doing stuff on their own, separate from what the public is offering. And so now we've got people in positions of authority talking mainly about those individuals who would use the public system, the ones who I'm saying we are clearly stigmatizing because we don't give them effective treatment.
Mm-hmm.
And now they're kind of using this term in this weird way, like we're going to actually reduce stigma by more effectively engaging people in stigmatizing services. Like what? Like whoa. Like how does that work? And the people themselves don't want to go because they can see what the services are all about.
Yeah,
it's about success is measured by retaining them. So the more days, the more months, the more years you're going and getting the medication that they're dispensing, that's success. But most people with addictions, when they're seeking help, they like help actually, like maybe simply getting off drugs, if that could be envisioned as a long-term objective. But what they see, what they're presented with, doesn't really give them any basis for thinking that that's going to happen. So people self-select away from these things, and no amount of talk from leaders about this convoluted way of referring to stigma reduction is going to persuade people that the services are actually more effective than they are.
So why would they measure it in the amount of days that a person is basically kept on the system? That sounds like a terrible idea. We want to get people off the system.
Yeah, I know exactly. This is the stigma in action. Yeah. The rationale that's given is that there is evidence that if people over a long period of time, our team has published evidence like this. If people are followed for a long period of time and they're receiving methadone, and you compare the times that they're receiving methadone to the times they're not receiving methadone, they are less likely to be convicted of crimes, to be hospitalized, and to die during the periods when they're on methadone versus off. Now, there are other ways of explaining why that might be the case rather than methadone works. Yeah. Right? It could be that people, to be on methadone, need to have better things going on in their lives. They need to be more stable. They need to be a bit more sort of optimistic that if they take care of themselves, if they do things for themselves, that they could get better. Whereas other times, their lives could be more chaotic. Not only chaotic in that they don't show up and take methadone, but more chaotic in that they could get into a fight or injured or overdose or commit an offense. So it's not clear, that the answer is methadone works. In fact, it's probably not the case.
You kind of brought it to that accountability piece, though. Again, is we're back to like maybe they're at a point where they're saying, okay, I need to change, even if it's just one other thing. It's methadone and one other thing. It's still more than the last guy did.
Exactly, and for many, the one other thing is not available. That is the only thing. Mm-hmm. I should point out that methadone didn't get started the way it's being used right now. When it was introduced, it was a component of a very well-rounded intervention plan that was organized. The success in these initial methadone programs was, first of all, people being off methadone and off other drugs too, but more importantly, being members of the community, and having jobs, being members of families, having stable lives that were fulfilling. And the idea is that by making lives that are inherently fulfilling, that's the best way to help ensure that somebody is going to remain free of addiction. Mm-hmm. So these initial methadone programs used the drug on a very time-limited basis, and it was not the main part of the intervention, but it's morphed over time. And now we have people in some of our research using methadone for 17, 20 years, no real change in their life circumstances. And this is being considered, this is now what's referred to as sort of methadone therapy. It serves a number of interests, right? It serves the interests of professionals, pharmaceutical companies, and those are now the main forces behind the promotion of an expanded public supply of addictive drugs.
Okay. I want to talk a bit about your career path, and then we'll get into the stuff about the database. So your career seems like it's mostly been focused on, from what I could read about it, was a lot of stuff on addictions, prevention, and then the reduction of use. So, am I correct in saying that? That's kind of been throughout the whole career?
Yeah, I've pretty much stuck with addiction since 1986.
So, you're a psychotherapist by trade. How does that come into this kind of world? Like, what are you doing when it comes down to, I guess, drug use, addictions?
Well, maybe the clearest way to answer is to summarize where sort of my training and early career took me. I worked with a psychologist named Bruce Alexander for several years. Bruce had done some animal studies on addiction. They're known. One group of these studies is known collectively as the rat park experiments. And it's basically showing that rats isolated in cages will show a preference for morphine solution over food. And if you take those same rats and put them into social settings where they've got lots of other options and things to play with, and including other rats, that they will quite markedly shift their preference to food over morphine solution. And this kind of lines up with a lot of other evidence from among human samples where you can't do those sorts of manipulations. So I went from there to working with Alan Marlatt in Seattle, and Alan at the time was one of the world's foremost addiction researchers in clinical psychology. So that's really where the psychotherapy components came in, and we had an incredible group of mentors, at least for people in the psychotherapy game. There were some of the world's best people in areas like borderline personality disorder. So Marsha Linehan developed an intervention known as dialectical behavior therapy that's kind of gone global. There was some of the world's greatest depression researchers, Neil Jacobson and others, and John Gottman doing marital and couples therapy. And we were sort of just all in this incredibly elevated, myself, and there were, 4 other trainees in my year. So it's a tiny little group of people. And you just get to spend tons of time with amazing thinkers and very gracious people. Mm-hmm. So I was so motivated through that experience. I took a job at UBC after I finished my training in hospital work, training new psychotherapists. So people who were going through the same type of experience that I had been through. And after about 5 years, I really realized that I could keep doing that. I could keep training. I could keep doing my own practice, and I would have almost no likelihood whatsoever of making an impact on addiction as I saw it in BC and in Canada. And so it was at that point that I started to make a shift toward government policies that are related to addiction, and doing research to show that the policies that we implement have a profound effect, and that we can do a lot better. I'm still trying to make that case.
Well, that's going to be one of the things I was going to ask was how much of your time is spent between, I guess it'd be practicing, research, and wherever else your work kind of takes you, which sounds like it's, I don't know, is it lobbying, you would say, or just research for government purposes?
Yeah, research with folks in government is what I've been doing. So I mean, but to answer your question about sort of like proportions of time, when I started, it was 100% clinical practice, then training clinicians, very little research. I just wasn't interested in that. And then over the last, I guess, maybe 25 years, it's shifted so that it's overwhelmingly now in the biz, I think we refer to it as knowledge translation, basically trying to get stuff that we know better into practice so it can make a difference, right? And that's kind of where I am now, but I spent about 15 years focusing the majority of my attention on doing research on clinical interventions. So still being a therapist, still thinking like a therapist, but mainly concerned about doing high quality research that could be published in peer-reviewed journals on how these psychological interventions helped people, and simply showing, what they were capable of achieving.
Well, and it makes me think of like in our world, being in policing, you have information and then you have intelligence. And it's essentially information is little bits of data all over the place. And maybe they can mean something themselves, but once you put it all together and mobilize it, now it can really, take off. It helps investigations. It progresses things. So, I kind of get what you're saying there. So with that kind of in mind, I wanted to talk a bunch about this article that was in the National Post recently. And then this has to do with a database that you created. So maybe I'll give a little bit of my understanding, but then I'll ask you to take us through, maybe chronologically would be the easiest way, or if you know a better way to explain it. But we'll kind of work through what this is and what's been going on. So from what I was reading in the Post article, and I'll post a link to it when I do put the episode up, just so people can read what you were talking about in there. You had this database, and it was called the Inter-Ministry Evaluation Database. You created this in 2004. And this is a database that, I got the exact wording that was used for it. It basically linked data about vulnerable populations across the various BC ministries. And I'll let you kind of explain what you were looking for in there. But this is like a very important database. It was used in provincial reports. It was cited in 60 different peer-reviewed publications. This is no joke. So can you kind of talk to us about, first of all, why this database was created? So what was going on in 2004 that made this happen? And then essentially, what is it and what it does?
Yeah. So there was in the late 90s, and some people might remember this particular work. It was led by a provincial judge in BC, Thomas Gove, and Judge Gove was asked to investigate the death of a very young boy, Matthew Vaudreuil, and because the circumstances of his death included the knowledge that many different care providers had encountered Matthew and had recorded their very serious concerns for his well-being and welfare, but they never communicated with each other. And so the resulting report by Judge Gove laid all this out and emphasized that people working on behalf of the public in government sort of frontline roles needed to be supported to share information more effectively, and that if they did, then some deaths could surely be prevented. So only a few years after that, I had been working already with some of the senior folks in the provincial government, different ministries, health, child and family development. And I started working with people in the justice area, so AG and Solicitor General. And they knew that this was basically a committee of deputy ministers. They knew that there were clients that they were seeing across their respective ministries who were not being helped by the ways that their different services impacted these people's lives. In fact, they were concerned that for some people, those impacts were actually net harmful to their lives. So imagine somebody who's, remanded, maybe there are always good specific reasons for what's happening, but big picture, someone's remanded and then they lose their place as a result of being away, and now they're discharged to homelessness, and now they're arrested and charged. So it's that kind of thing. So I was invited. It was really their idea. This is in 2002. I was invited to do a 2-year project, a proof of concept, to see if it's possible to link information at the population level for people who are seen across multiple different sectors. And the ones of greatest interest were health, justice, and social welfare. Those three. And, just for young folks, you got to be reminded that there was a time that some of us remember before personal computers, and where these were open questions like, can we link all this information? Can we derive some useful meaning from all this digital stuff we're collecting? So, as I said, we spent 2 years doing that. The key focus was on, at the time, this is kind of an anachronistic term, I think, prolific offenders. But at the time, in the early 2000s, that was a big concern. And how many of the people that were calling, this label also have been diagnosed with mental illnesses, maybe have been hospitalized for mental illnesses? What about substance use? There were other sort of thoughts, the so-called mentally disordered offenders. There was this kind of jargon in use. So we started to compile information. We showed that indeed we could link information on everyone in BC, do it safely and securely, and that we could, not only that, but we could produce some intelligence or some meaningful results from all this data. And so one of the first things we showed was that it didn't really, the likelihood of being reconvicted after initial conviction did not go up if someone was diagnosed with a mental disorder, say like depression, even schizophrenia, compared to people who'd been convicted without any diagnosis. However, if someone had been diagnosed with a substance use disorder, the likelihood was substantially greater, like 2.5 times greater, that they would be reconvicted. And if they had been diagnosed with a substance use disorder and a mental disorder, it was over 3 times the probability. So that really got us launched. And in 2004, as you said earlier, we really started from this proof of concept phase, moving into what was then a steady state. And we continued to use these data, add to them based on evidence of need or rationale, right up until 2021.
I want to just maybe get a distinguishment between mental health and then the addiction side of things. And I was trying to think of this, like, how do I even ask this question? Because some of this stuff's above my head. But and it might be a bit of the chicken and the egg argument, but can they be in the same conversation? Like, so mental health, how I might know it as somebody who knows nothing, but it's like an imbalance of chemicals or hormones or something in the body. But drugs is like an outside factor causing things to your body. So do drugs just cause mental health, or is it like one and the same? Or can you even talk about them in the same breath? Like, does that make sense?
Yeah. These are for sure. We have not, and your question reflects that we haven't done a great job explaining what's going on in mental illness and in addiction. We use euphemisms all the time, right? Like we don't talk about mental illnesses. We talk about mental health or mental health problems or things that don't even make sense, like mental health disorders. Like you mean mental illness, right? So we have this very vague and confusing landscape of terms that really doesn't advance things very much. it's important to note, I guess, for starters, that the way that we classify mental illnesses, including substance use disorders, is all in the same context. It's all in the same framework.
Okay.
And also that every single diagnosable condition is based on things that we can observe exclusively. That is, there is no biological test for any mental disorder. So what's been promoted as biological imbalances and things of that nature appears to have been overstated. Overstated in terms of its significance. Not that there aren't differences, but that they are not necessarily differences that signify the underlying cause of the symptoms or the source of distress. Pharmaceutical companies and biologically minded people would love that it was so, and of course love for the public to believe that is in fact what's happening. That is that their molecules are correcting the underlying biological imbalance. But now decades of research have shown that that is not the case. And that what we see in terms of biological changes associated, say, with addictions are very similar, in fact, overwhelmingly the same, whether we're talking about an addiction to alcohol, an addiction to opioids, or an addiction to gambling.
Okay.
Right? So these are, and the signature that explains these biological differences is more consistent with what we know about learning and how people learn and orient to rewards. And but the fact that they're the same among people whose addictions don't involve drugs is hugely meaningful. So there is overlap also between what we call addictions and other disorders. They'll differ in terms of the core symptoms, the defining symptoms. So, for example, there's a lot of overlap between anxiety disorders, mood disorders like depression, and substance use disorders. And I think in the general public we know this, right? Like people are sad and self-medicate, or anxious and self-medicate. And that's kind of how we put it together, I think, in common sense. But it's still the case that with anxiety disorders, there is a central feature that is not the same as substance use, say the experience of trauma. Or in the case of mood disorders, there's a central feature, let's say very low mood, depression.
Yeah.
Other things can be the same, but these central features differ, and they overlap. But substance use and substance use disorders. Now, I'll give the example of poisonings so much on people's minds these days, so-called overdose. About half of people who survive a poisoning episode were suicidal at the time of the poisoning, and the likelihood of experiencing suicidal thoughts goes up the more prior poisonings the individual has survived. So there's very clear evidence of a kind of a leakage across different so-called types of mental disorders, where what differs is that kind of cardinal feature. Is it mainly about depression? Is it mainly about trauma? Is it mainly about substance use? But linked to these central features is a kind of a mess that can be true across multiple so-called categories of disorders.
Okay. Well, so when kind of getting back to the database on this, so this database was kind of measuring a whole host of factors. And like you were saying, it had to do with health, justice, social welfare. So what were some of the things that you were mentioning once this database was up and running? And then can you kind of walk us through, where the studies led, and then what you're into now?
Oh, yeah. Okay. So one of the areas of interest, and maybe I'll add just as a sort of something that runs through all this, is I approached all this whole phase of my work, still as a psychotherapist, and my attention now was the government, people in government. I was trying to think of how would people in decision-making roles be most likely to use information that points to opportunities to improve things for people that I'm concerned about. And so in order to do that, I thought it would be important to develop the research questions with those people, the people who were trying to help and people in government. I thought it would be important that government should mainly sponsor this research. If they really think it's useful, then what better way of showing that than to fund the research? This is not, by the way, this is not super expensive research. My salary's always been paid for by the university. So there are salaries for trainees, like graduate students, that kind of thing. It's not terribly expensive, but still, if government's willing to put up, 20,000, 50,000 to do a project, then I have greater confidence that they're likely to read the results versus if I, get a grant and do the study and then say, hey, here, like read this.
Yeah.
So we proceeded more or less in that way, doing research on questions that were important to folks in the province or federally. So, hey, we've got that drug treatment court. We got a drug treatment court, and it's expensive. It's seeing thousands of people. Is it working? How about that community court? How's that? What about street outreach teams? What about integrated approaches, cross-ministry approaches to try and address homelessness and crime among people with mental illness? How's that going? Where, by the way, so all these questions we've answered and they're published and available in most of them openly available to members of the public. We tried to get as much of our work into the public domain versus behind a journal paywall. But all these things that we've answered. So then we got to, well, where are the heaviest concentrations of people in BC who are basically in some kind of a proverbial revolving door? They're in and out of hospital for mental illness. They're in and out of jail. They're they're requiring income assistance and emergency shelter grants. So, how many people are there who meet different levels of criteria, like 10 or more offenses, 2 or more hospitalizations, these kinds of things. Where are they? And what happens over time? Back to the amazing thing about computers. We can now look at over 10, 15 years, do people start off in communities with these kinds of struggles and then move, or do they stay there?
Yeah.
What happens? So we did a lot of work like this, mapping where there's evidence of need, detailing which of the interventions that we're currently funding are resulting in comparatively positive outcomes for people. And we've also, with people's consent, accessed their data as they are participating in randomized controlled trials. This is probably our clearest way of identifying differences in interventions, where we can actually randomly assign people to intervention A, intervention B, intervention C, and then stay in touch with them for several years.
Yeah.
And see how things are going. So it provides a very clear insight and into things where you really need these kinds of administrative data, because the timeframes are long. People don't always remember, like, was I in hospital? Like, what was that for exactly?
Yeah.
And they may not always want to say, right? Like, they'll give us access to the information to use it confidentially, protect their privacy. But if we're asking people straight up, hey, were you in prison and they were remanded, but it was something they disagreed with and they really didn't like it, they're not always going to say yeah, right? Yeah. So we used the information in that way. The last thing that we did was we showed the province that there were really alarming increases in the frequency of involuntarily hospitalizing people for substance use disorders or for mental disorders, like either one, that they'd more than doubled over a period of a few years. And we also showed that in our provincial corrections facilities, the proportion of people that were detained, whether it's remanded or sentenced, and people who know the system will realize in Canada that there are large proportions that are remanded to custody, it's about 50-50 in BC, remanded versus sentenced, but they all wind up basically, it's like involuntary hospitalization, they're being involuntarily detained, right?
Yeah.
For every single one of them, if you open the door, they would leave. So it's involuntary, and the proportion that had been diagnosed with a mental disorder, a substance use disorder, or both before they were locked up had gone from something like 45% to over 75% in that same few-year window. And it was shortly after that we were sort of asked to step down.
So, yeah, one thing I want to point out, and maybe it's like a really good summary of what you're saying here, is so the database basically measured days spent in hospital, detentions, criminal convictions, medications, and income assistance. And I thought, like, that sounds like a great way to measure things. You're covering not just the health side, but you've got some of the justice side, because it all overlaps. And then it was kind of accurately measuring the impacts of government policies. So I'm guessing this was showing that policies weren't working, or at least not as they were maybe saying they're working.
Well, things were clearly getting worse in recent years in terms of like the things that I've mentioned, the numbers of people involuntarily hospitalized, numbers of people convicted who were experiencing mental illnesses and addictions. We also see that's not a finding that any government should really be so embarrassed by that they're going to suppress it. I mean, the much more damaging finding in an obvious sense is the numbers of people who are dying.
Mm-hmm.
And if you simply think through, like, how can you have a death crisis that escalates?
Yeah.
Right. As we do with poisonings, because just to sort of think that through from a basic way, month over month, year over year, if you've got an increasing death crisis, you need to be replacing the numbers of people in crisis faster than you're killing them.
Yeah.
Right. So the deaths are the tip of an iceberg. And if the deaths are going up, the iceberg's getting bigger.
Mm-hmm.
Right. So where else do we see the iceberg? Involuntary hospitalizations, numbers of people incarcerated. We're using our institutional capacity more and more to contain other aspects of the iceberg.
Yeah.
Right. Before people wind up perishing. And so this, I think, in an obvious way, should all hang together for people in decision-making roles, and more importantly, I guess, provide some insight into where government can begin intervening. We had also, by this time, like only a couple of years ago, we'd completed those randomized trials. And one of the key things that had been shown, and this is across the country, was that it's possible to intervene with people who've been homeless for 10 years, who've got like 10 convictions on average, who've been hospitalized a bunch, all experiencing serious mental illnesses and addictions. It's possible to, in year one, achieve immediate, massive reductions in the likelihood of being convicted. So the precise number is a 71% reduction versus leaving them where they are, and about a 50% reduction in medical emergencies. And the kicker is the intervention costs the same as leaving them out on the street.
Huh.
Right? So we had put this together thinking along COVID lines, because remember, COVID, we have this crisis, we do some randomized controlled trials, we figure out the vaccine works better than the placebo. And then the next step is, okay, how fast do we get the vaccine out to as many people as possible? It's about implementation. So we had the same thing. We had this crisis, this intervention costs the same. And the results are just massive. So let's talk about implementation. So we drew up an implementation plan, and 1 week, 1 week after delivering the implementation plan, we got a letter out of the blue saying, thanks for the last 20 years. Please arrange to destroy the database in the next 3 weeks, sanitize your hard drives, and then confirm in writing that you've done that. Thanks again. That's how that went. And needless to say, the current provincial government has no interest whatsoever in taking the results that have been generated as any basis for what they're doing in response to these crises.
And is this just them basically not wanting to admit that what we've been doing hasn't been working? Does it kind of boil down to just that?
There seems to be some of that, but there also is a group that people who have much more sway than me in the BC scene, who are strongly in favor of expanding a publicly funded addictive drug supply, what they refer to as safe supply. And some of them are some of the senior people are themselves owners or co-owners of drug companies. And this is not like this is not some private information that I have. This is in the public domain. Or vending machines for drugs, and they're among the people who have really been responsible for public health decision making in BC for a number of years, and who are on the inside. And they've been successful in persuading people in decision-making roles that they are right in what they're advocating for. And, for whatever reason, no one questions whether these individuals have conflicts, or even if they have the qualifications necessary to be designing addiction policy for British Columbians. It's key to just observe that what's happening here in BC with the combination of decriminalization and a public supply of addictive drugs is unique on planet Earth. And if you look at what people in my field have been writing and concluding even recently about what policy directions we should be going in, the one large study led by Stanford University and the Lancet Medical Journal, and known as the Stanford Lancet Commission, they list in this 51-page document many things that we should be doing in order to help reduce the crisis. Actually, a lot of them are being implemented in Alberta, but among the things they say not to do, they list two. One is, no place should be implementing vending machines to dispense drugs, or try to introduce a pharmaceutical supply of drugs in the hope of displacing the illicit trade. So these are the two things they say, by the way, don't do these things. Those two things are at the top of the BC agenda.
Really?
So it's just a remarkably backward, insular approach that we're taking that really has self-interest all over it, and the public just has not been informed yet.
It's maybe a little lighthearted on this, but just it's funny talking about all this and all the backdoor deals and those types of things that could happen. And then I just picture a guy in his coveralls wheeling in the vending machine, and somehow he gets involved in the conversation. And it's like, this guy is not part of the normal circle of people. Like, how'd the vending machine guy get in on this deal?
Exactly. Yeah, exactly.
But I mean, bringing things to light, I feel like we're supposed to be in an open society where we can offer solutions and not shut people down. I think most people know that. Some of the stuff that's happened to you is like your project has been shut down. You've been getting silenced in different ways. You also had, I guess, some people lobbying against you speaking at like some sort of event. So was that successful? Like, did you end up getting stopped from attending, or were you permitted to speak?
Yeah, there's it is especially in BC. There's a very I've learned limited tolerance for dialogue on issues relating to drug policy, actually relating to anything that questions what the people in power are promoting. So some colleagues and I did a review on the public supply of addictive drugs. So this is what advocates refer to as safe supply. We didn't use the term because it seems to suggest that there's already some evidence of safety.
Yeah.
To commend that title, and we didn't know that there was, so we chose this more descriptive title, and we published this review. We showed that there at the time wasn't any evidence demonstrating the effectiveness of what was being recommended, and we raised a number of questions that also hadn't been addressed, such as what would the eligibility criteria be.
Mm-hmm.
So, one of my concerns is people with serious mental illnesses. It is. I hope most people will see that it is kind of on the face of it a bad idea to contemplate giving combinations of methamphetamine, cocaine, or other stimulants to people who have bipolar disorder, and where you could trigger mania, for instance, or there are other just clearly dangerous potential interactions with serious mental illness. So what are the eligibility criteria? Because those have not been written down anywhere.
Yeah.
What about the types and mixtures of drugs that would be dispensed? And what about frequency? Like for how, and you need these in order to actually even have a chance to answer another key question, which is, what's it going to cost?
Yes.
So the fact that we are not answering these preliminary questions means that we can't even estimate year one costs, year two costs. And then what's the exit ramp? Like, what's then what, right? So we raise these questions, and the authors of the papers advocating for safe supply, their term, went immediately to media, got on the evening news, said no one should read this report, it's a piece of poop. And then they found out where I was scheduled to talk and started writing to conference organizers saying, hey, you got to uninvite this guy. So this is from the BC Center for Substance Use, is where this is the group that's doing this work. Mm-hmm. They've remained just really, really nasty. They're writing to people in government roles, saying that I'm not qualified to address issues, that the fact that I'm involved means that they're going to withhold any advice that they could give because they're so offended. And it's I was not expecting this. Yeah. Like, I knew that we were on different sides of issues, at least different sides in that we saw things differently. But I was fully anticipating when we started to raise some of this that it would generate a discussion.
Yeah,
but
a dialogue.
But instead it's triggered this backlash, which now makes me more sort of suspect that they don't actually have rejoinders. They don't have any kind of science behind their position. Mm-hmm. They're now feeling threatened, and they're trying to simply shut me up. But so far that's not working.
So one of the things I want to make sure we touch on is kind of some of the solutions. And this is mentioned in the National Post article talking about the Portugal model. I think people have completely bastardized whatever this model is. I don't think anyone actually knows what it is. Can you explain it and tell us, are we trying to emulate that here in Canada, or are we just cherry picking certain things and making a mockery of this whole thing?
So fortunately, Canada is a big and varied place. And so depending upon which region we focus on, my answer would be different. fortunately, well, in some cases we're doing actually a very high fidelity job of implementing the things that Portugal did that are translatable to our context and that really are the active ingredients. And the province that stands out most for being down the track on this is Alberta. But other provinces are following suit also. They're studying the architecture and are going down that same path. BC is about as kind of retrograde as you could imagine,
Really?
in terms of cherry picking and just really kind of missing the plot. But let me. I didn't answer your question. Like, what did they do? So in 2000, they introduced this national strategy for the fight against drugs, and one element of it was to change the legal status of possession of drugs from a criminal offense to an administrative offense. Prior to this, police were really not having too much to do with individuals over drug possession. It's like way too frequent. They had the worst open air drug scene in Europe, the highest rates of death. And almost all Portuguese towns had places where there were these open air drug scenes, people living rough. And it was a true like social crisis. So they introduced a massive and multifaceted plan that of which decriminalization is as a tiny part. The people responsible, many of them are around today, still in roles of responsibility, and they're on the record saying, if all we did was decriminalize, we would have made things much worse.
Oh, because that's about the only part anyone talks about in Canada, outside of basically just building people free homes.
Yeah, it really shows the strength of pharmaceutical companies as influencers on public dialogue, because they provide funding to researchers, they provide funding to create research positions, and then they influence the federal government in terms of where our tax dollars go for research grants. So it's a big, incestuous pro-industry movement or industry influenced movement, and that doesn't have there's no alternative kind of commercial interest to stand up against that. It's kind of like standing up against the National Rifle Association or something. Like who's the industry group that's going to do that?
Yeah.
The arguments, by the way, are very similar, right? It's the same absurdity. It's not drugs that are killing people; it's the wrong drugs. So what we got to do is increase the supply of the right drugs, and that's how we're going to save lives, right? It's like guns. It's not the guns are the problem. We need to get more guns in the hands of good people to protect it, right? This is the argument. So Portugal had, they're anti-drug.
Yeah.
Portuguese people don't see taking more drugs as a good thing. It's not a lifestyle choice. So they enabled police using an administrative sanction to get in people's faces, go up to them and say, you've got to come with me to what's known as a dissuasion commission. The Dissuasion Commission is kind of a neutral, intermediate body, neutral in the sense that they are not the front door of their own treatment center.
Yeah.
But they take the person that comes with the police, they hear what the situation is, and they say, okay, our role really is to help make sure that you don't come back here. So depending on what the person's circumstances are, the ones that required housing, help re-entering the workforce, maybe like months to years of stabilization, establishing a sense of community, the reciprocity of being a citizen without drugs. They had 64 therapeutic communities, 0 consumption sites.
Yeah.
You only need consumption sites if you've got a population of drug users who are homeless. If you're prepared to address housing need, and I think of this as harm reduction. A big part of my training was in harm reduction. if someone is homeless, has no job, has no friends, has untreated mental illness, we can reduce the harms of all four of those things.
Mm-hmm.
And if we do that, we give them a much greater chance of addressing their substance use problems. And that's what our research has done over these many years. So Portugal, armed with a massive investment in therapeutic communities and other community-based resources. So not everybody needs, that multi-year thing. Some of them need a place to live and a support worker. Some of them need, various things in between. But they came with all of those resources and a commitment to implement them. And that's really, that's how they made their difference.
And this was nationwide, so there wasn't like individual provinces all picking their different strategies.
So they have the benefit of being able to describe, design, and implement a nationwide strategy. And of course, in our setting, we do that at the provincial or territorial level mostly. So that's why we see a huge level of familiarity with what Portugal actually did that resulted in change, with works like the Stanford Lancet Commission's work that I referred to, and other kind of major important examples of guidance documents from the addiction field that are addressing these issues. And then we have, on the other hand, we have BC that is not paying attention to any of those documents at all. In fact, if you bring them up and they just people don't want to listen to them, they make fun, or they mock the idea that people can overcome addictions. When I have presented to the current government here in BC evidence related to recovery from addiction, eye rolling. And just sort of sidelong glances, and I get comments like, well, not everybody's ready to embrace religion or go to AA meetings, as though that's kind of what I'm talking about, because it's not. Mm-hmm. That's got relatively little to do with actually understanding the fact that people recover from addiction, which has Portugal's case is powerfully illustrative. What makes the biggest difference for most people is not any kind of a formal program or a professional intervention. It's having a different relationship with the things that are around us every day. Your family, your friends, your work, neighbors, community involvements. It's cultivating relationships. It goes back to something we touched on earlier, that sense of the possibility of being a different, healthier person, not knowing how you're going to do that, but at least having the sense that that's attainable, maybe even necessary. Sometimes it's with a gun to your head. You have to make this decision, right? Yeah. But it's getting to the point where that's possible. And then the things that make a difference are not experts. It's the way we build a life around us involving other people. The fewer experts, the better, right? For most people.
Yeah. Well, I think we kind of covered most of what we were looking to get to today. Is there anything you think we missed? I don't want to cut you off or anything, so I want to make sure we get everything that we can.
It's been great talking to you, and we've covered a lot. I'm sure we've missed a ton. Is this where we go to the call-in portion?
Yeah, I'm not that popular. Nobody's calling me. I do want to make sure, give you a chance to say how people can follow your work and see what you're up to.
Awesome, thanks. So I'm using the Summers Psych handle, so SOMERSPSYCH, and you can find me on the web, Twitter, Insta, please have a look. And I'd love to be in touch with people. I'm new to the sort of the whole social scene, but really getting a lot out of reading what people are saying, comments, direct messages. I think it's a really important time. I mean, this is not like my my wheelhouse, right? Social media, but I'm committed to it because I think that this is a really important time for dialogue.
Yeah.
And the experiences I've had getting shut down by my academic colleagues just further reinforces to me that, okay, this is very important. We've got to come together. Portugal made their shift because they had established a degree of consensus. They had enough talk among enough people to say, okay, this is something everybody has to be a part of. If you don't see yourself as part of the solution, then there's something missing, because everyone needs to play a role. And I think that's where we are in Canada right now. So yeah, so thanks for mentioning that, Nathan. If people want to connect, I'd be thrilled, and hopefully together we can come to some real consensus and begin making a positive difference for people.
Yeah, I don't think it's an unreasonable position to simply ask for dialogue. So thanks for coming on and giving us time. If you can hang on a second, I'll say bye offline.